My name's Shari Blanch, and as it says on the screen, I'm an architect and a researcher at Jacobs, and I'm based in Brisbane in Australia. So I'm going to be talking today about post-occupancy evaluations for healthcare facilities. And it's a topic that I'm very passionate about. And ever since I started working in architecture, I've always been very curious as to why we design health facilities the way that we do. And so that's led me to this particular field of research. So let's jump right in. So there are 4 sections to the presentation today. Firstly, a little bit about POEs, and POEs is the abbreviation for post-occupancy evaluations. I'm going to continue to refer to them as POEs throughout the presentation. Secondly, some context about Australia and Aotearoa, New Zealand. That's where the research that I've undertaken is based. Thirdly, what was our research about? So I'll talk you through some of the key findings. And lastly, I'll give you some final thoughts and some more resources if you wanted to dig a little deeper into the topic. But first, I wanted to start with this quote from the CSIRO, which is our leading government science and research organisation in Australia. And they state, if the system does not adapt, research shows our healthcare spending will bankrupt the nation by 2100. And they're specifically talking about Australia here, but I'm sure it's a similar situation in many countries around the world. The cost of healthcare is continuing to increase at a pretty unsustainable rate. So in Australia, healthcare expenditure per capita has doubled in the past 20 years. And in New Zealand, it's risen by about 150%. And so what the CSIRO is saying is that we need to start to do things differently in healthcare in order to curb this spending, or we're going to be in a pretty dire situation. And how do we do things differently? Well, we need to be able to assess what's working and what's not working in our facilities. And that's where POEs come in. So I'm going to talk briefly about POEs in case this term isn't familiar to you. So what is a post-occupancy evaluation? So it's typically known as an evaluation of a building and is usually undertaken about 12 months after a building has been occupied. So in the health sector, a facility would be designed and constructed and the staff would move in. And then about 12 months later, a team would conduct an evaluation on that facility. Now that's a really basic bare bones definition of a POE, but it's actually quite a difficult thing to define further than that because in the literature, a POE can go by many different names and it can have very different scope. So I've heard them be called building performance evaluations, project reviews, building reviews, lessons learnt, and benefits realisation, among many other terms. And in terms of scope, a POE can also be very wide-ranging. So an evaluation could focus on purely sustainability features of a building, or it could focus on patient outcomes. So it really depends on what the evaluation is seeking to measure. So in that sense, there's no standard methodology for undertaking a POE either, because the methodology then relies on what scope that you're looking for. And in short, a POE can come in many shapes and sizes. Why are they important? So it's a bit of a cheeky image on the right. It's a somewhat obvious example of how things can go wrong in a project. But essentially, a POE provides an opportunity to understand if the intentions of a project have been met or if there's anything that can be changed to improve the facility. So, for example, if a project sets out to improve staff retention in a facility and provide a better environment for staff, then this can be measured to see if that's been achieved at the end of the project. So if I talk to the quote from the beginning, these evaluations can provide a sort of feedback loop to help us evolve our health system and improve on the return on investment for our facilities. And we can start to see where investment is best spent to improve health outcomes and then contribute to improving the health system overall. And so when I say feedback loop, I mean feeding the results and information from evaluations back into future projects, and then help in improving future facilities. So the results can be used to inform future project functional design briefs and project briefs, business case assumptions, and they can also help in a more macro sense to develop the health design body of knowledge and to contribute to evidence-based design, or EBD, as it's often called. Okay, so I'm going to move on to some context about Australia and Aotearoa, New Zealand. So that's where our research has been based. And I know many of you might not be familiar with the health system in these countries. I think most of you are based in the US. So I'm just going to give you some context about that before moving forward with the research. And just something else to note here is that you might not be familiar with the word Aotearoa, but that is the Maori language name for New Zealand. Okay, so I've shown here the size of Australia and New Zealand in relation to North America, just to give you some idea of geographical context. So they're very similar sizes, but Australia only has 25 million people, and New Zealand has 5 million people. So they might seem like relatively insignificant countries because of their small populations, but they're important to consider in the context of post-occupancy evaluations and evidence-based design in healthcare, because they're ranked as some of the best health systems in the world. So if other countries are using our systems and facilities as exemplars, then we should be designing them with rigorous evidence-based design principles. Some more context for you here. So most healthcare in Australia and New Zealand is publicly funded. So in Australia, it's about 70% publicly funded, and in Aotearoa, it's 95% publicly funded, so quite different to the US for those of you who are based there. And this is why we've chosen to focus our research on public health care facilities primarily, because they affect the majority of our population. So this is a map of all the states and territories of Australia, which you may or may not be familiar with. And it shows New Zealand off to the right there. So in Australia, each state or territory is actually responsible for their own healthcare management and delivery in that region. So it's not a federal system. And I'm going to refer to them as jurisdictions because states and territories is a bit of a mouthful. But I have some statistics here to show you how different some of these regions can be. So if you look at the Northern Territory in the top at the middle there, it's a relatively large geographical jurisdiction, but it actually only has less than 1% of our population in that area and only 6 public hospitals. So you can understand that they have quite a lot of challenges in delivering high quality healthcare to a lot of people that live in very remote parts of that territory. Whereas if we look at a smaller state like Victoria, which is the bottom right there, which is where Melbourne is, they have a quarter of the population of Australia and over 130 hospitals. So their challenges are quite unique and quite different to the Northern Territory. They need to provide high level of healthcare to a lot more people in more urban environment and a lot of rising demand in that area. So every jurisdiction has unique challenges like that in their healthcare delivery. And they all have quite different governmental structures about how they procure healthcare facilities as well. And so the summary of all of this is to say that it's the responsibility of each of those jurisdictions to then undertake evaluations on their facilities as the owners and operators of those facilities. And lastly, in this section, I just wanted to let you know about the Australasian Health Facility Guidelines, which I'm not sure if you're aware of. So these are free guidelines that are available online, and they give advice on how to design healthcare facilities in Australia and New Zealand. So they've been around for about 17 years in different iterations. And they have guides on how particular departments are supposed to work. So for example, emergency departments or intensive care units. And they also have information on every room that might be used in a healthcare facility. So you can see here, there's information on bedrooms. That's just the top of the list. And this information has critical dimensions, the types of finishes that room needs to have, all the equipment that room needs to have. That would usually be in those sheets that are off to the right in the PDFs. So whilst these are guidelines, they're often written into our contracts with government clients. So we do need to pretty much abide by them or say how we're deviating from them. Why is this relevant? It's because, well, if this is the place where we're getting our information on how to design facilities, it makes sense to me that this is the place that any results of building evaluation should be included. And then the results could inform any updates to the guidelines, so future facilities are then continuing to improve. And I'll come back to this a bit later. All right, so into the research. So as I said earlier, I conducted some research on POEs in Australia and New Zealand with my colleague Annabelle Fraser at Jacobs, and I'm going to talk you through some of the results. So from a methodological perspective, we conducted a focus group in each jurisdiction, and we spoke to a couple of government employees in each of those jurisdictions. Those government employees were employed in capital infrastructure departments within those within the government, and we asked them about how they undertake POEs on healthcare facilities. So we asked them what the process was, how those evaluations then related back to those guidelines that I was just speaking of, what they thought the value of POEs might be, any barriers that they had to undertaking POEs, and then finally how they disseminated those results. Okay, so the first outstanding result was that not a lot of POEs are being undertaken in either country. So almost half of the jurisdictions don't undertake any form of evaluation on their healthcare facilities. There are 5 that do some form of POE. There are varying frequencies between those 5, and only one of those jurisdictions actually mandates the process. So what does this say? If these POEs aren't being undertaken, or if they're being undertaken rarely, then we have very limited data available to know how our facilities are performing, and therefore limited data to improve our future facilities. There's no standard template or clear scope. So the image on the right here indicates the areas of scope available to undertake an evaluation, and each of those dots represents one of the jurisdictions that do currently undertake some form of POE. And so the various areas are service, analysing the client experience; physical, analysing the building's technical performance; functional, analysing the health service performance; and financial, analysing the value for money. And so this reflects what I was saying a bit earlier in the literature, that there is such a variety of definitions of a POE and such a variety of scope available to evaluate. So there's no clear-cut path to undertake a POE. And you can see here it's quite a variety of scope areas that the jurisdictions focus on. So over half of the jurisdictions we spoke to believed that a POE must have a clear, precise, and limited scope to provide value. So I have a few quotes here that I'll read from some of the focus group participants. So the first one here is, the value could be so wide-reaching, but it's just where to put your limitations on scope, really. Targeted evaluations rather than a one-size-fits-all, being really clear about what you're looking to evaluate to make sure there is value. And a lot of POEs are trying to be all things to all people, and that's where we think they fall over. And I think this relates quite strongly to the slide before, where you can see that there's the possibility to evaluate almost anything in a health facility, and the scope can be so large, but just because you can measure everything doesn't necessarily mean that you should, and doesn't mean that there's value in measuring everything. So 2/3 of the jurisdictions cite that the potential reputational damage to government organisations prevent the public release of any information. So this is a really critical point, because there's definitely a perception in literature that POEs can be a form of an audit on a project, where you're looking for what's gone wrong and looking for someone to blame. And because of this perception, we're missing out on the opportunity to find out what actually worked well in a project and celebrating that success and building upon that in future projects. So there's a really important piece in changing the perception of a POE from an audit. And that's, something that needs to be worked on, but is difficult in a political context. So set up the measurements for evaluation at the beginning of a project. So 7 of the 9 jurisdictions believe the measurements for evaluation should be set up early in project stages to ensure that they're then measured after construction. So this means understanding what the project goals and objectives are at the beginning and finding tangible ways to measure these goals at the end. So, for example, in a project, if a goal is to have more improved patient observation by staff, how is that going to be measured? What is the current scenario? How is that going to be improved? And that could also lead to a pre-occupancy evaluation where you're finding what the baseline is to improve upon that. Another example is what benchmarks were used in the strategic planning phase of a project or in the business case. So, for example, if you had 12 consult rooms that are predicted to be required in an outpatient facility during the business case phase, the evaluation could then test the occupancy rate of those 12 consult rooms and see if those benchmarks were then accurate. And feed the results into future projects. So this is where it's really important to start seeing the project delivery process as cyclical rather than linear, as was shown on the previous page. So the evaluation is what then closes that feedback loop and creates a process of continual improvement. Often because a POE is done so long after a project has been completed, it's something that's forgotten about because the whole project team's moved on to a new project, or funding has then been redirected to something that's deemed more critical. But if it's set up at the beginning and then integrated into the project, there's a higher chance that it'll be undertaken and then can provide valuable information. And as I said before, one of the most important places that I see the results from any of these evaluations being meaningful and valuable is influencing the updates to those Australasian Health Facility guidelines. And finally, for the results in this section, over half of the jurisdictions agreed that top-down support is vital within government to ensure that evaluations occur, which means having more senior management understand the value of POEs and how evaluations then can inevitably contribute to a better return on investment for health facilities or more bang for your buck. So this isn't necessarily something that our research has a solution for. It's really dependent on the structure or the hierarchy of the organisation, so of a government organisation or even a private client organisation, and who needs to approve the POE. So the challenge in Australia and New Zealand, it's really unique to each jurisdiction. All right, some final thoughts and resources. Future research. So this research is really foundational and will continue, hopefully, because there hasn't been any research conducted in Australia or Aotearoa to understand how POEs are undertaken by jurisdictions, specifically on public healthcare facilities. So it inevitably confirms a lot of the elements that are written about in POE literature about some of the barriers to undertaking POEs. But it's a valuable piece of research as a starting point or a springboard to continue to research in this space. So I'm hoping to continue in this year on that. And I'd like to specifically develop more of an understanding on what the key metrics and measurements are that do provide the most value in an evaluation. So going back to that piece of scope, so that the evaluation doesn't seem like an insurmountable task or something that's incredibly expensive to conduct, but something that's more achievable. All right, so if you're wanting to undertake a POE, what should you do? I've put 3 considerations here. So firstly, create a team that understands research methodology as well as health design and health systems. So in my opinion, this is really important because if a POE is undertaken poorly, or if it doesn't have enough rigor, then the results aren't going to be valuable. And this is going to contribute to people thinking that POEs might not provide that much value for how much time and money they cost. And that goes back to that top-down piece as well, proving that these things are valuable. Number 2, establish a clear scope. What do you want to find out? So make it really specific and measurable, and ideally related to what the initial project's aims are. So going back to the brief, the business case of the project. And thirdly, disseminate the findings. So help build that body of knowledge in health design so that everyone can benefit, and then our health systems can grow stronger and hopefully not go bankrupt. All right, so some resources. This is our research paper that Mohammad was talking about earlier. If anyone wants a copy, I think Mohammad can give you my email address and I can just send you a PDF of that. I also spoke about this topic on the Australian Health Design Council podcast. It's about a 19-minute listen, and the website's available there on the screen if you wanted to listen to that. There are some other really good speakers on that podcast as well, not necessarily always Australian-based either. Wolfgang Presser has written a wealth of information on post-occupancy evaluations, and this is a really good book called Building Performance Evaluations. So that's Presser's terminology for post-occupancy evaluations. And he prefers this terminology because it sees the evaluation cycle as more of an integrated part of the entire project cycle, rather than something that's done, right at the end after 12 months. And so it's similar to what I was talking about before. I tend to use the terminology post-occupancy evaluation because it's more commonly or widely known. But as I said before, everyone has a different terminology for it. So it can be quite a difficult topic to research. And Boissonneau and Peters have written a few really fantastic journal articles on POEs in the last couple of years as well. So there is one paper about performance areas, which is similar to what I was talking about earlier about scope of a POE. So they look at, it's a huge systematic literature review on every paper they can find on post-occupancy evaluations and what people look at performance-wise. It's not necessarily just based on health either. It's in all of the sectors. And they've also done another paper on POEs in a Canadian context, which is the screenshot there. So I wanted to finish with this very famous quote that I'm sure you've all heard. Those who do not learn from history are doomed to repeat it. So I think that's very relevant in the topic of POEs and using evaluations to continuously improve our healthcare facilities. We have to be doing them.